recording will go through the question and answer session at the end. Dr. McKay, the floor is yours.
Great, thanks, Patrick, and welcome everybody to the, gosh, I think we're in the 4th or 5th installation of our seminar series this spring. So this is a joint seminar series between Global Public Health, the interdisciplinary minor on our campus, and the School of Community and Public Health Sciences. Today, we're going to be hearing from one of our own, from Professor Ethan Walker, who recently joined our department, and we're so happy to have him as part of our program. And he's going to be talking with us about impacts of wood burning Justa cook stoves on indoor air pollution and some other related matters. So a little bit about Ethan. Ethan is an assistant professor here in the School of Public and Community Health Sciences, the University of Montana. His research focuses on the health effects of air pollution from wood stoves and wildfires. He received a PhD in environmental health with a specialization in epidemiology from Colorado State University in 2019. And his doctoral research focused on the health effects of biomass cook stoves used in lower and middle income countries, which is the subject of his talk today. Previously, Ethan graduated from the University of Kansas School of Nursing and had worked as a registered nurse before he attended the Colorado School of Public Health. So we're so pleased to have Ethan with us today, and I'm going to let you take it away from here. Thank you, Ethan.
Great, thanks a lot, Kimber. Appreciate that introduction, and thanks everyone for joining today. All right, so as Kimber mentioned, I'm going to present on a study that I've been a part of since I was in grad school at Colorado State University. So some of the results I'll present today were part of my PhD dissertation, and I continue to collaborate with this group regularly to finalize these results, to work on publications from the study. So I do need to start by just thanking everyone from our team at CSU for putting together this presentation. Our group recently presented some of these slides at a global health webinar in January, so I'll do my best to represent all of their hard work and all the work that went into the study. So this was a huge project. I'll try to present it succinctly and do it some justice, but I also appreciate any questions, clarification after I finish up. So with that, I'm gonna start out today just giving some background information on this randomized trial, as well as information on cook stove related research, because I'm not sure what everybody's background is on this type of research. So we'll start out with that, and then we'll get into some information on exposure and health assessments in the study, and then some conclusions, trying to tie this all together and show where we're at in this type of research and what comes next. So to start us out here, nearly 40% of the global population uses solid fuel cook stoves. So these stoves use wood or coal fuel, and these are primary cooking devices in households all across the world. 40% of the global population is a huge number, and these stoves are often primitive stoves with limited ventilation. It's essentially like cooking with a campfire in your living room. So these are used daily and multiple times a day. They're often left just smoldering throughout the day. So they really increase indoor air pollution, household air pollution inside these households. And unfortunately, they also disproportionately impact women and children, as women are the primary household cooks in many of these homes and regions. So with this risk factor, this is a top 10 risk factor globally for death and disability. We also know that this is not a new problem. We've known about the issue of cook stoves and household air pollution for decades now, and have been studying that for years. The problem is that fixing this issue is incredibly complex. The majority of people who use cook stoves like this live in lower and middle income countries across the globe, from Central and South America to a number of countries in Asia and Africa. Cook stove use is prevalent throughout many of these areas, but there are countless different cultural norms and cooking practices within these different regions. So that makes it nearly impossible to design really a one-size-fits-all solution of cook stove design that could really help improve the indoor air pollution in all of these households. So you really need to work with interventions at a community level. What works for one community will not work for another. And cook stoves need to be culturally appropriate before individuals will really even consider adopting a new stove. Looking at ourselves, lifestyle changes are hard for all of us. And when you think of how important cook stoves are in the lives of the people who use them every day, if we were to be asked to adopt a different type of cooking method to replace our largely electric and gas stoves, that would be a big ask. So lifestyle changes are a big issue in this problem globally. Another issue is infrastructure. The best solution might be to get everyone on the electric grid and give them access to electric stove, but that's not happening anytime soon. And so this is an incredibly complex and intimidating problem. And there's question of where we go from here in cook stove research and in trying to discuss interventions surrounding this issue. So one thought then is to replace more primitive stoves with improved biomass cook stoves. So instead of cooking indoors over what's essentially a campfire, individuals could use an improved wood stove with a chimney that improves ventilation and a combustion chamber that improves the burning efficiency of the stoves. Now, stoves like this aren't a perfect solution, but they might be better than the alternative and a good interim solution until better technology is more widespread. One of the first groups to look at this kind of solution and study this did a cook stove intervention trial in Guatemala called the Respire study that you see on the top part of the slide here. So the primary outcomes in this study were child respiratory infection, and they found that the improved wood stoves did somewhat reduce child respiratory infection. It did reduce indoor air pollution, and it improved blood pressure somewhat in the adults in the study. However, while these findings are encouraging, indoor air pollution still remained very high after the intervention, and other studies have not been able to really replicate these results in a consistent manner. And it just shows how difficult these interventions are and how much better solutions are needed. So other studies have looked at cleaner burning interventions such as LPG or liquid petroleum gas stoves to replace wood stoves. And stoves like this typically do reduce indoor air pollution compared to wood stoves, but improvements in health have still been inconsistent. And so the question remains, well, why is this? And it could be a compliance issue where participants continue to use their wood stoves alongside these gas intervention stoves, or maybe there's just too much air pollution around the communities, and we need to think more holistically about community-wide air pollution to reduce community-wide interventions to reduce total air pollution exposures. So regardless, it's clear that we need better research and better solutions to improve the health and quality of life in the billions of cook stove users around the world. So this brings us to the current study that I'll talk about. And this study took place in rural parts of Honduras from 2015 to 2018 is when the actual field work took place. Now, most of the population in these areas in rural Honduras, 90+% of the households use wood stoves as their primary cooking device. So it's a very prevalent issue in rural Honduras. And so that's kind of setting the stage for what's going on in the study. Now, the aim here was to fill in some ongoing questions in cook stove research. First, we wanted to identify a culturally appropriate, improved cook stove that would be accepted by this community and hopefully improve compliance within the cook stove users. And this study, traditional cook stoves were destroyed and they were replaced by these improved Justa cook stoves. So the Justa cook stoves were identified through community-informed research, and they were built into the houses after the traditional stoves were destroyed. The Justa stoves included chimneys to help improve ventilation, as well as combustion chambers to help improve the burning efficiency. They were culturally appropriate in that they had large griddles that women could cook on, tortillas, and then large pots of food. So they really met the needs of those in the community. I've talked some about how community-informed research was such an important aspect to the study, and these are just some photos that highlight this. The effort that went into identifying a culturally accepted cook stove that would fit the lifestyle of the community members, the study leaders met with community leaders and got input through different community meetings. They met regularly throughout the study to provide updates, and also partnered with local organizations to help facilitate this research and build these stoves inside the home. So really important aspect of this research that I think led to the success of the study. So once the improved cook stove was identified, the study took place over the course of 3 years in the field. So field staff visited each household twice per year for a total of 6 visits within each study household. Exposure and health measures were collected during each of the study visit. And again, this was a randomized trial intended to test the efficacy of the cook stove intervention. So there were 230 households with one primary participant per household. And these participants were all women who were the primary household cooks within the home. They were randomly assigned to one of 2 study arms. So this random assignment occurred during a transparent, culturally accepted method where they literally just blindly picked their own study arm assignment from a bag during a community meeting. So there was no question of the treatment arm assignment. And when they were picking it themselves and knew upfront what intervention they would be receiving during the study. And this was called a stepped wedge study design, where participants in arm 1 received the Justa cook stove following the second study visit, and then participants in arm 2 received the Justa cook stove after the 4th study visit. So it's a staggered design. Interventions were not delivered at the same time. And this really makes it more logistically feasible in a field setting rather than trying to build all of these stoves all at once in these varying communities. The participants received the intervention prior to the end of the study, another strength of this that helps improve participant retention. And then having multiple baseline and follow-up visits in each study arm really, decreases variability in the outcome measurements and leads to an overall strong study design that's appropriate and really ethical to deliver in this type of setting. So now we have a little background on the study. I'm going to talk some about the exposure assessment and the health outcomes in the next few slides. So quality exposure assessment is an extremely important aspect of cook stove intervention studies because we really want to know how much the intervention actually reduced air pollution to test the efficacy of these stoves. So the problem with this is that air pollution is extremely complex. There's hundreds of pollutants in air pollution. So it's impossible to measure all these different pollutants. So we often use a proxy to represent what exposure was before and after the intervention. So PM2.5 or fine particulate matter is commonly measured in these studies as a representation of exposure. And it's measured typically because it's a little easier, a little more accurate to measure than other types of exposure, and it's got very strong associations with adverse health outcomes. So it's a good measure of what the exposure is to air pollution. Now, PM2.5 is particles that are less than 2.5 micrometers in aerodynamic diameter, and these can be inhaled deeply into the lungs, and they have known to cause numerous adverse health effects. But how do you measure this, and what exactly is aerodynamic diameter? Now, air pollution particles are kind of like snowflakes. No 2 particles are really alike, and they're definitely not perfect spheres. So essentially, aerodynamic diameter means that these particles behave or travel through the air like particles that are 2.5 micrometers or less in diameter. And measuring these particles is easier said than done. So in this study, we used pumps that pulled air through a device called a cyclone. And the cyclone swirls the air around in a manner that selects out PM2.5 while larger particles are discarded. Then the PM2.5 is then deposited onto a filter, like what you see in the photo on the top left here. And these filters are weighed before and after the sampling. So when you subtract out these pre and post sampling weights, you're left with essentially just the mass of the PM2.5. And this is a very time and labor intensive method, but it is considered the gold standard for measuring PM2.5 in these types of studies. So we did this, we measured indoor PM 2.5 by hanging monitors near the cook stoves, and we also measured personal PM 2.5 by hanging monitors on the participant themselves, and they wore them for a 24-hour period during each of the 6 study visits. You can also see on this slide that we measured black carbon. This is kind of a component of PM 2.5 that in some cases has stronger associations with health outcomes. And you can assess black carbon using the same filters that we collected the PM 2.5 on. And then later I'll talk a little bit about predicted long-term average PM 2.5 in black carbon. So we collected PM 2.5 6 times during the study, but that's over the course of 3 years. So there is a question of how well that represents their actual exposure when we're only looking at 24-hour measurements over the course of a 3-year study period. So you can use repeated measures of these exposures to actually estimate a long-term average of the exposure for each household. So it's a better representation perhaps than these 24-hour measured exposures. So I will also show some results for these methods as well. So what were the PM 2.5 levels in these homes, and how did the Justa stove impact PM 2.5? So the figure on the bottom right here, this is showing some box plots that just shows the spread of the PM 2.5 samples across each of the study visits. This is on a log scale. So you can see that the concentrations in some of these cases are very high. There's a lot of variability in the measurements. And for personal PM 2.5, the median concentrations then were around 81 micrograms per cubic meter for the traditional stove users and around 43 in Justa users. The kitchen PM 2.5 that was measured near the stove itself was a 178 for traditional stoves and 53 for Justa stoves. So what this comes out to is that the Justa stove intervention resulted in 32% lower PM 2.5 for personal PM. And for kitchen PM 2.5, it resulted in 56% lower PM compared to traditional stoves. These are pretty impressive reductions in PM 2.5, especially considering that this is still a wood stove that's being used in these households. So just the improvement in ventilation and combustion resulted in these large reductions in exposure assessment. Quickly showing some results for black carbon. We see very similar trends to what we saw for PM 2.5, perhaps even larger percent reductions though, where black carbon, personal black carbon, we saw a 53% reduction, and kitchen black carbon saw 76% reduction. So again, very meaningful and impressive reductions in these pollutants after the Justa stove intervention. All right, now getting into a little bit on the health outcomes we measured in the study. So as a reminder, we measured health outcomes during each of the 6 household visits. There were 6 repeated measures then of each of these health outcomes within household. The primary endpoints were blood pressure, hemoglobin A1c, and C-reactive protein. Hemoglobin A1c is a measure of blood glucose. C-reactive protein is an inflammatory biomarker in metabolic outcomes like hemoglobin HbA1c or hemoglobin A1c, and C-reactive protein. They're typically less studied in cook stove research compared to things like respiratory outcomes. So our focus on cardiometabolic health in this study was also another big strength of the study. We're still working on some results for C-reactive protein. So today I'll just focus on the HbA1c and blood pressure results. We also measured a number of secondary health endpoints, telomere length and other inflammatory markers, some other hemodynamic markers like augmentation index. So those will be subsequent papers in the study. And we collected a lot of other questionnaire data on health conditions, stove use and behavioral aspects in the study, sociodemographic characteristics, and other potential confounders. So we'll start out with looking at hemoglobin A1c, and this is a measure of long-term blood glucose over the previous 2 to 3 months. So typically, a lot of times what's measured in health and research is plasma glucose, which fluctuates wildly depending on time of day, your fasting status, your diet. But hemoglobin A1c is this long-term, more stable measure that's more appropriate for field studies like this, that aren't as affected by these short-term differences. It's also easy to measure using point of care devices. So you can use a small device like you see here in the picture, take a drop of blood, get results in 10 or 15 minutes, and then report that back to the participant and kind of talk through their health results with them. There is also previous evidence of that air pollution can adversely impact hemoglobin A1c and other related outcomes like diabetes and insulin resistance. But these outcomes haven't really been studied closely in cookstove research, so that there's this big question of, can improved cookstoves lead to an improved metabolic health and related to diabetes and insulin resistance? So the first step in our analysis then was seeing if, first of all, the randomization worked. Now, randomization in these studies is intended to control for both measured and unmeasured confounding factors in the trial. So in theory, since participants are randomly assigned to study arm, factors like demographic and socioeconomic characteristics that are traditionally pretty hard to control for in a study, they should be equally distributed across both study arms and have minimal impact on our analysis and results. It's always good to check this assumption. So that's essentially what we're looking at here in this table. You can see the age, things like age and school, education, body mass index, hemoglobin A1c, they're all pretty relatively equal across the two study arms. So it's not perfect, but overall, we do see seemingly successful randomization of the study participants and really equal attributes across both study arms. For the primary analysis, we used linear mixed models in three different types of analysis frameworks. So linear mixed models, because the outcomes we're looking at are continuous in nature, and mixed models because we want to account for the repeated measures within participant. So the first framework we looked at was the intent to treat analysis, or the ITT analysis. So this is really looking at the efficacy of the assigned stove on the health outcome. And so we included a randomized exposure type then was the exposure of interest, randomized stove type, was the exposure of interest. Model covariates included a spline to account for time in the model, and then a random effect for participant. Now, in the next model framework, self-reported stove use, we did this because some participants may not have used the cook stoves as they were assigned. So we looked at self-reported stove use in this framework to see if that had a different impact on the results of the study. And these models also didn't utilize the study's randomization, so we had to include potential confounding covariates in these models. And then finally, we see the exposure response models at the bottom. This was a third model framework. So we're really here looking at associations between household air pollution and the health outcomes. So did the health outcomes increase as PM2.5 and black carbon exposures increase? So these are kind of the three big analysis questions that we're looking at. So for hemoglobin A1c, in this first intent to treat analysis, we're looking at, again, the efficacy of the assigned Justa intervention. So A1c was slightly lower in Justa stove users compared to traditional stove users. Now the estimate in this analysis, these results, it's relatively small, but it is in the direction we would expect. So the Justa stove reduced hemoglobin A1c, or reduced long-term blood glucose. And there's evidence that the Justa stove resulted in small reductions in HbA1c in study participants. So as I mentioned previously, the intent to treat analysis was looking at assigned cook stove, which can be different than the cook stove that was actually used. So in the bottom table here, we're looking at results considering the effect of self-reported stove use. Now, the categories in this analysis are a Justa stove with or without an improved secondary stove, a Justa stove with a traditional secondary stove, or just the Justa stove only, and that's the reference in our analysis. And what we see here in these results is that the Justa stove has an even larger effect and reduced hemoglobin A1c even more than what we saw in the intent to treat analysis. So in overall encouraging results, some good evidence that the Justa stove did improve hemoglobin A1c. Now, in this last table for HbA1c, we're looking at exposure response association. So we're not looking at the impact of the Justa stove, but rather associations between measured air pollution exposures and HbA1c. We can see here that personal PM2.5 and black carbon exposures, as they increased, hemoglobin A1c levels also increased in the study participants. So that's what these results are telling us. So there appears to be an exposure response association between these exposures and outcomes. The associations are larger for PM2.5 than black carbon, and then larger for long-term average exposures compared to the 24-hour measured exposures. This table is really only looking at personal exposures, but the area or kitchen exposures had very similar results to what we see here. All right, and last I'm going to look at results for blood pressure. So this was measured using within the participant households using a device called the SphygmoCor XL. That's what you see on the left photo here. This is a cuff-based system that measures brachial blood pressure. So what most of us are used to in healthcare, a blood pressure cuff. The measurements were taken within participant households. Women were in a seated position after a rest period, so a pretty straightforward measurement on these blood pressure assessments. In this table, we're looking at summary statistics for blood pressure at baseline or visit 1. And really the things that stand out are systolic blood pressure was around 121 millimeters of mercury on average, diastolic pressure around 74. Systolic pressure had quite a bit more variability in the results, larger standard errors, and this did impact the statistical models that we looked at. In general, though, we see that these outcomes had similar measures across the study arms 1 and 2 at baseline. So again, this indicates successful randomization in the study. And next we can move on and look at our primary outcome results for blood pressure. So in these next few slides, since I'm looking at 2 separate outcomes, systolic and diastolic blood pressure, I wanted to try to just represent these with figures and graphs rather than a bunch of tables. All of the following figures they're showing estimates, these point estimates, and then 95% confidence intervals. And then the tables and the figures are showing the number of observations in each analytical model and stove type. So in this first figure, we see the primary intent to treat analysis results. So again, the impact of the Justa stove intervention on blood pressure, and in general, we see very small estimates and wide confidence intervals from this analysis, and there's not really any evidence to suggest that the Justa stove impacted blood pressure. So unfortunately, somewhat discouraging results for the primary analysis here. This next figure, though, is looking at this self-reported stove use analysis. And what we see here, that unlike that intent to treat analysis in the previous slide, we do see some evidence that participants who use the Justa stove with a secondary traditional stove had lower blood pressure compared to traditional stove use only. Now, for some reason, we don't see similar results for Justa users who used an improved secondary stove. So the big question is why this might be. Often those secondary traditional stoves, when they're used outdoors in areas with better ventilation. And so participants may actually spend less time indoors and have less air pollution exposure if they use a secondary stove outdoors. So it's possible that women who use these stoves just had less exposure, and that's why this stove use group had seemingly a slightly lower blood pressure than traditional stove use. There are other potential factors and studies like this, like confounding measurement error or selection bias because of losses to follow-up, but we really didn't find a lot of evidence for that type of an internal bias in the study. So the takeaway here is that, these results are very complex, but there is some evidence that the Justa stove with a traditional secondary stove led to improved blood pressure in the participants. All right, finally, in these last 2 slides on results, we're looking at, again, the exposure response association. So did increasing PM2.5 and black carbon lead to increasing blood pressure? There are a lot of results here. I'm just going to focus on trends, but we really don't see much evidence of an association between PM2.5 and systolic blood pressure. They're wider confidence intervals, very small estimates. So it doesn't seem like the household air pollution measures impacted systolic blood pressure. However, what I've highlighted here on the right side is that there are small associations between household air pollution and diastolic blood pressure. small associations, I'm talking less than or equal to 1 millimeter of mercury higher diastolic pressure per log unit increase in PM 2.5. But they're similar for personal and kitchen PM 2.5. So there might be something going on here where these household air pollution exposures are impacting blood pressure in the participants. Now this slide is looking at the exact same analysis, just looking at black carbon instead of PM 2.5. And again, we don't see associations for systolic blood pressure, but some smaller associations for diastolic pressure. That may be smaller in magnitude than what we saw in PM 2.5, but very similar trends in this analysis. Right, so we just went over a lot of results. I just want to summarize briefly before I get into some concluding slides. But first of all, in the intent to treat framework, we really didn't see an impact of the Justa stove on blood pressure, but potentially an impact on hemoglobin A1c. In the self-reported stove use analysis, there's evidence of improved hemoglobin A1c among Justa stove users, and then some evidence that the Justa stove users who use a secondary traditional stove had improved blood pressure. Finally, in these exposure response associations, we saw small associations between hemoglobin A1c and diastolic blood pressure with the household air pollution exposures. So overall, fairly positive results, although we didn't see really meaningful changes in blood pressure in the study. All right, so these final slides, I'm just going to kind of wrap things up, bring this home and try to tie these results together and give them some context within this kind of body of literature and what comes next. First of all, though, strengths and weaknesses, there's a trade-off in any field study like this. There's a balance of strengths and weaknesses. The stepped wedge study design that we use, that it can have benefits and drawbacks both. In this design, we're really limited to 2 study visits, at visits 3 and 4, where there were different stove types across the 2 study arms. And this can somewhat limit power in the study and our ability to detect differences across the assigned stoves. But this type of randomized study design is hard to do in a field setting. And doing a design like this, where each participant and household had multiple pre and post intervention visits, and each participant received the intervention prior to the end of the trial, it leads to more ethical study design and better participant retention than some other methods. This is also one of the largest longitudinal studies with repeated measures that's been done in cookstove research. And it's true that longer studies can lead to more participant dropout, but we actually had, I think, given the community engaged approach, we had really good retention on participants across the course of the study. So we were really happy to see that most participants stayed in through the whole thing. And that community engaged approach was such an important aspect that helped with retention, but also just selecting this culturally appropriate cook stove that participants were glad to receive and glad to use. You can give people the best cook stove that money can buy, but if they don't use it, it's not going to make a difference. And what we found, that even though this is a wood stove, still participants accepted it and really were happy to receive this stove and incorporate that into their lifestyle. Other strengths were high quality exposure and health assessments that improve on many previous studies, and including these kind of less studied cardiometabolic health outcomes is a really important aspect of this study. And then, there's certainly trade-offs in this type of field work. It's hard to do in these rural areas. No study is perfect, but the design and the methods that we use really had a lot of strengths that I think add to the results that we've found here. All right, so putting this all together, what are our takeaways? We did see overall reductions in household air pollution, but the measured air pollution concentrations were still relatively high, even after the intervention. And they were substantially overlapped between Justa and traditional stove users. So I think there's still this lingering question of, is this good enough for now? Is this good enough for these households, improving indoor air pollution enough? But regardless, it did improve indoor air pollution on average, and it could be what we're finding is a feasible interim solution until these households have better access to cleaner energy sources. For the health outcomes, we did find evidence of beneficial impact of the Justa stove on hemoglobin A1c levels. And given the rising global health, global prevalence of metabolic conditions like diabetes, I think these findings are really important. They're important contributions to cookstove research and really improve our understanding of household air pollution and metabolic health, and provide a possible solution on, if participants use these types of stoves long term, maybe we can somewhat improve metabolic health like this. Unfortunately, we didn't see these strong findings for blood pressure, although there was evidence of small associations between the household air pollution and diastolic pressure. And I think one of the most important aspects of this is the positive impact that the stove had on the lives of the women who use them every day. And this was a before and after photo of one home where a woman went from burning on essentially a campfire, no ventilation, no stove, to having a better built-in stove that still meets the needs of cooking within the household. And it's hard to measure some of these intangible, unmeasured improvements in quality of life. It's a difficult thing to grasp, but I think that some of these photos really show some of that improvement and give hope for future studies like this. Even if we don't see what we want to in the analysis, we think we're still improving lifestyle and the quality of life in the studies. And so finally, just to wrap this up, and we can have some questions, but a lot of studies have found that cookstove interventions do reduce indoor air pollution, household air pollution, but the impact on health outcomes has been less conclusive in general. So that's why our results for hemoglobin A1c are encouraging, but we still, it's not clear why we don't see improvements in blood pressure and why other studies have not seen the same. So it's possible that these improved stoves just aren't reducing exposures enough to improve blood pressure. It's possible that we're looking on the wrong time frame. Maybe short-term studies and short time frames aren't long enough to capture reductions in things like blood pressure following interventions. So that we might have to look more over the course of a life, life frame from interventions in children to see how that impacts some of these health outcomes later in life. So overall, our study really shows the utility of these improved cook stoves, and I think gives a lot of potential and what we can do in the interim before better technology is more widespread. With some of these lingering questions, I think this makes some really important contributions to this area of research. So I do want to give a big thanks to the many collaborators, partners, and field staff, especially the participants who made this work possible. And with that, I can kind of wrap up here and leave it open for some questions if anybody has anything.
Thank you, Ethan. Looking through hands up here, and I've got some questions myself. Looks like Curtis and Gil Quintero do as well. Curtis, I saw your hand first. You want to lead us off?
So I'll defer to Gil. Go ahead.
All righty then. Yeah. So a great presentation. It was really, really interesting, Ethan, and glad to learn more about your work. So one thing I'm wondering about is, I think all these sort of like biomedical or physical measures are really important. I'm wondering if you have a sense of kind of the other sorts of data and variables is in terms of like, I'm just thinking about how these stoves might have changed the cooking experience that these women, typically women, realize, and how they evaluate these new stoves in terms of just like the experience of cooking, the quality of cooking, in terms of the experiences they might have had with more traditional stoves. Do you have any sense of that?
Yeah, that's a good question. It's a really hard thing to quantify, and I think part of that might come down to like compliance of using an intervention stove, and how much are they actually using it. I think that could be kind of a proxy of how useful it is, how accepted it is in these households. Because if they're kind of reverting or deferring to the traditional stoves again, that might call into question, how actually useful and impactful it is in the lives and in their everyday lives and in their cooking, and does it really meet their needs? We use temperature monitors on the stoves. We would put a little temperature sensor on the chimneys to assess when they were being used. So we could kind of capture cooking events when the temperature would rise and fall. And we looked at that across the traditional and Justa stoves. And we really found that the Justa stoves were being used. And I think compliance was pretty good from what we found. So it is a hard thing to identify though. Yeah, that's a good question. And I'd be interested to hear other thoughts on that.
And then if you don't mind a follow-up, I mean, in terms of like cleaning and upkeep of these stovepipes, I'm wondering, are there any issues there related to sort of sustainability? Are these stovepipes gonna kind of get resin buildup, creosote buildup? Is that an issue? Do you know?
Yeah, it is. Part of the intervention included kind of training and education on upkeep of the stoves, and there's a local organization that our group partnered with to kind of help with that upkeep. And so participants knew who to contact then if they had problems with the stove, if they needed a replacement part or something like that. So I mean, similar to our own homes, nobody's going to be perfect in upkeeping like their HVAC system or something like that, but they did know who to, like, they had resources and education for things like that. So yeah, good question.
And then finally, just the last note, Bonnie Young, she worked with me as a graduate research assistant back at New Mexico. So I'm happy to see that she's, gone beyond that and apparently is a colleague of yours. So I think that's really, really cool and kind of an expected connection. Anyway, thanks for your talk.
Yeah, thanks, Gil. That's great to hear. Bonnie was amazing. She led the entire field study when she was a postdoc at CSU. She lived in Honduras for years and led all this work and just really made all this possible. So she was really instrumental in this study. That's great to hear.
That's a cool connection, Gil.
Go for it, Curtis.
Thanks, Kimber. Ethan, since A1C was the most prominent result in these studies, what is the current thinking with respect to the mechanism whereby PM or smoke or black carbon is causing changes in A1C?
Yeah, I think people kind of keep going back to inflammatory pathways. And then kind of sustained inflammation can lead to changes in sustained changes in metabolic processes. And I think that's kind of the base mechanism, is just, the initiation of inflammatory pathways that can just affect systemically any kind of health outcome almost. And I think that's where most of that, most people kind of point to that pathway. Is that what you were asking, Curtis, or do you have other thoughts on that?
No, it is, but it's not entirely satisfactory, I guess. If like inflammation is like whatever, it's like saying it's oxidative stress, or what exactly is happening? It's a mystery, I think, and that it'd be nice if there was more of an understanding of that.
Yeah, no, definitely agree, and I am not really entirely sure, to be honest, of what some of those more specific, beyond inflammation, what some of those more specific pathways are through which household air pollution can impact these types of outcomes. I'm more familiar with some of the more cardiovascular outcomes and vascular inflammation and things like that, but I think it's a little bit of a mystery, I think, as to what mechanisms can impact some of these hormonal type pathways. But that's a good question, and I would like to keep learning more about that.
And not to dwell on this, but I don't suppose in this study there was any observed changes in eating patterns because of the different cooking modalities.
Yeah, that was a big concern about potential confounding. Did the introduction of a new stove change eating habits, cooking habits, which could then impact some of these metabolic outcomes? And we did look a lot. We kept, it's all self-report, but we asked at every study visit records of typical dietary intake and things like that, and tried to control for that. There's always the possibility that, there's residual confounding in a study that could impact results, but, did the best we could to try to control for that.
Erin S., I see your hand has been up.
Thank you, Kimber. These are great questions and really good presentation, Ethan. I feel like I learned a lot. So you left, you sort of ended up with this message of hope, which I loved. So first there was the intervention improving indoor air quality by this huge percent, but it's still something like 100 micrograms per cubic meter. So we know from being in a wildfire impacted community, if the PM is that high, that is just really, really high. I mean, that's just really polluted air, but still it's a massive improvement. So that's something to really celebrate, right? And then, and you talked about quality of life, that there's some sense, even if maybe it's not improving it enough to see these big, equally large impacts in health, maybe it is changing mindset or just well-being or overall sense of well-being. And so that made me wonder if you might, if you had collected any information on that. Maybe, it's always, you can add every instrument you want to a study for sure, but was there any way that you could sort of measure that, or at least from conversations with participants that you get a sense of that?
Yeah, that's a good question. We did assess health symptoms, which I think could be maybe one aspect of not directly assessing quality of life, but self-reported health symptoms, they definitely have limitations, but you're also maybe in some aspects assessing how people are feeling, or however subjective that is. I think that may be a good way to kind of answer that question indirectly. We haven't done a primary analysis looking at those health symptoms, but leading up to this study, there was a R21, a cross-sectional kind of informative study in some of these households, where I looked at self-reported symptoms cross-sectionally, and they were substantially lower numbers of self-reported health symptoms in Justa users compared to traditional users. And so I would be interested to see if that was the case in this more longitudinal study. I don't know. Do you have any? I don't know a good way to assess quality of life and that somewhat more subjective measures in a field study like this. And again, you're limited in what you can ask and assess in a limited amount of time. But I don't know. That's one thing that comes to mind. Any other thoughts on that?
No, but it just reminds me that that's a really, just moving forward, that's a really good thing to try and, I don't know if quantify is the right word, but try to assess in participants, because how people's outlook and their sense of optimism or hope, I think is really, to alter that is, would be a really big achievement as well. So anyway, great presentation.
Ethan, was there a reduction in fuel use and wood use? Because in the very, very early days of these improved cook stoves, decades ago, the focus was really on reducing wood consumption, and because women would spend tons of time collecting wood. Yeah,
absolutely. And that leads to other risks and lifestyle and things like that. We did. I don't know that we actually quantified fuel use in this study. That wasn't a primary objective. Actually physically measuring that. We again did kind of self-report on fuel use, and the stoves themselves have a limited opening to the combustion chamber that I think fuel use had to be reduced, but quantifying that and knowing exactly how much it was reduced, I can't really tell you, unfortunately.
Ethan, you know, we've worked on this with the team that I work with in the Himalayas since the late 90s, and we did quantify a number of these things, including fuel use, and the impact was non-trivial. So there, the usage went down, but the labor went up, which was also non-trivial from the women's perspective, because they had to process the wood a lot more. And I think I shared that with you before.
Yeah.
But some of the other related measures that ended up being important in the Himalayan households, which are very different from these households in the sense that people are also heating their homes with these stoves. So that, you know, it's in the Honduran mountains, I think probably in the wintertime, they probably do need some heat, but in the Himalayas, they really definitely do.
Yeah.
And a couple of other things that were going on were improvements to subjective well-being related to how much less the women had to scrub their pots because the amount of soot on the bottom of the pot went way down, and also just on the interior of their home. And then also burns in children went way down. So there were a lot of burns that were pediatric burn data because the kids were falling into those open fires. And so we just actually a month and a half ago finished 700 household survey, including stuff on stove use and related behaviors. So if you want to talk about that, you can, we'll just see each other in the hallway. So yeah, still very interested in understanding this uptake of this particular innovation and all the subjective stuff around why people do or don't adopt it, and related concerns. So I see we're up against the time, and it's always a wonderful thing to see all of the questions and interest. And again, so pleased to have you speaking in the series, Ethan, and having joined our faculty. And thank you so much for a wonderful presentation. And to listeners, next week we're not meeting because it's the federal holiday. And the week after that, we're going to be welcoming one of our own from medical anthropology here at UM, Michelle Grokey, who did her PhD in some of the same households I was just talking about in the Himalayas. And she is going to be presenting her research, which is about the development of a local and culturally appropriate and culturally driven schema for subjective well-being. So kind of moving subjective well-being measures and scales onto a very local or into a very local frame. And so Michelle's going to be talking about that and the relationship between subjective well-being and those households having recently undergone a nutrition transition. So that's something to look forward to. That's 2 weeks from today. Again, next week we don't meet. And thanks everybody for listening, and we'll see you again soon.
Thanks a lot, Kimber. Thanks everyone.